Hello friends, welcome to the Pathology Insights, and today in this video we will be discussing about the rheumatic fever. It's previously it was called as it licks the joint and bites the heart. So we will see what are the changes which occur in the rheumatic fever and what are the pathogenesis in this. So this is an immune-mediated disease, rheumatic fever, and this usually occurs after the patient has pharyngitis because of the group A beta hemolytic streptococcal. So initially the patient develops the pharyngeal infection with the group A beta hemolytic streptococcal. Later on the antibodies are formed in order to eliminate this bacteria, and these antibodies which are formed against the antigens in this bacteria, they cross react with the many proteins or many molecules in our body. The antibodies which are formed here, they cross react with our own proteins in or our own molecules in our body, and it becomes an autoimmune disorder. That's why it is an immunologically mediated multisystem inflammatory disease, because many organs are involved in this, and usually it occurs 10 days to 6 weeks after the infection, because this is the time period which is required for the development of the antibodies. And also the rheumatic fever develops in only about 3% of the patients who develop the pharyngitis because of group A beta hemolytic streptococci. Not all the patients who develop this infection will develop the rheumatic fever. Only 3% of the patients will develop. Now here the genetic susceptibility plays a role in this. So people who are susceptible, they only develop this rheumatic fever. And nowadays the mortality is reduced because of the improved sanitation, rapid diagnosis, and the appropriate treatment for the streptococcal pharyngitis. Now coming to the risk factors, so usually the age group where it develops is acute rheumatic fever. It occurs most commonly in the children aged 5 to 15 years. Then we have a recurrent episodes which will be affecting the older children. And finally, the chronic rheumatic heart disease. It usually occurs in the children, but prevalence it peaks in the adulthood. So recurrent attacks occur and the patient develops the rheumatic heart disease. So usually we find the rheumatic heart disease in the adulthood. But acute rheumatic fever, the common age group is 5 to 15 years. And when we see the sex, acute rheumatic fever, it is more common in both males and females. There is no gender predilection. But the rheumatic heart disease, it shows a slight female predominance. And other environmental factors which are responsible are the poverty, overcrowding, and undernutrition. This also can lead to the rheumatic fever. Now coming to the pathogenesis, as I told you, this is mainly caused by the infection, initial infection caused by the group A beta hemolytic streptococcal, and the antibodies are formed against the various antigens which are present in this bacteria, and again these antibodies will cross react. So when we see the structure of the streptococci, it has a cell membrane and then it has a cell wall, that is a peptidoglycan cell wall, which contains group A carbohydrate antigen, rhamnose, and an acetyl glucosamine. And then we have outermost capsule, which is made up of the hyaluronic acid, and it also has a pili, and this pili, they contains mainly M protein, lipotecoic acid, R, and the T proteins. Now here the structures which mainly act as an antigens are the M protein, because this M protein has an alpha helical protein structure. On the similar structure we see in other organs also, like in the myosin, keratin, laminin, and the vimentin. Even this also have this alpha helical protein structure. So the antibodies which are formed against the M protein, not only against the M protein but also against group A carbohydrate antigen and N-acetyl glucosamine, all these antibodies which are formed, they cross react with the myosin, keratin, laminin, and vimentin, which is present in the different organs in our body, because the structure is similar. So the main antigenic component is M protein. Also it is group A carbohydrate antigen and N-acetyl glucosamine. Now this streptococci, it also produces certain extracellular substances like streptolysins. Again in this we have two types, streptolysin O, which is oxygen labile, and streptolysin S, which is oxygen stable. then hyaluronidase, DNase, streptokinase, and pyogenic exotoxins. Now, by the time the patient develops a rheumatic fever, this beta hemolytic streptococci would have been disappeared. That's why in the patient with acute rheumatic fever, if we take the swab for the pharyngeal culture, it will come out to be negative because the infection would have gone, but the antibodies which are formed against these antigenic components, they will be causing damage to the tissue. So we don't find the streptococci in the culture, but instead, if we see the titers of the streptococcal enzymes like streptolysin O and DNase B, these will be raised. So we can detect these enzymes, and we cannot detect the bacteria in the pharyngeal culture. Now, what happens when we get the infection? So initially, we have the pharyngeal infection. So the bacteria group is streptococci. What it do is it activates both innate immune response and humoral immune response. So innate immune response is this streptococci, it directly activates the sentinel cells which are present in the tissue, the first defense mechanism. So we have macrophages, dendritic cells, and the lymphocytes which are present in the subepithelial tissue. So these cells, they get activated. Macrophages and dendritic cells, they engulf these bacteria, try to remove them. During this process, they get activated. So when these cells are activated, they produce inflammatory mediators like IL-2, IL-6, IL-8, interleukin-2, interleukin-6, interleukin-8, 12, tumor necrosis factor alpha, and interferon gamma. These mediators, they have two functions. Mainly, they activate the macrophages, facilitate the phagocytosis so that organism can be eliminated, or otherwise it promotes the differentiation of the B and T cells. So two functions it does. It eliminates the organisms and also it promotes the differentiation of B and T cells. Along with these interleukins, macrophages, they also produced angiotensin 2. Now this angiotensin 2 is mainly responsible for the fibrosis. This is what happens when there is activation of innate immune response, and it also activates the humoral immune response, which causes the formation of the antibodies. Now, once the dendritic cells and the macrophages engulf the streptococci, they process and they go to the lymph nodes and they present the antigen to the T cells and the B cells with the help of MHC molecules. So CD4 plus T cells, it differentiates into T helper cells, and T helper cells again, they activate the B cells. So these B cells, when they are activated, they get converted into the plasma cells, and these plasma cells, they produce the antibodies. So antibodies which are produced here, they are used to control the streptococci, destroy the streptococci, and another thing is these antibodies, they produce the antibodies, they go and damage the tissue like the skin, heart, brain, joints, and endothelial cells because of the molecular mimicry. As I told you, the M protein of the streptococci, it has similarity with the keratin in the skin, laminin, tropomyosin, troponin, actin, and myosin in the heart, then gangliocytes in the brain, vimentin in the joints, then vimentin and the laminin in the endothelial cells. So all this has a similarity with the M protein. So antibodies which are formed against the streptococci, they also cross-react with all these molecules. And small minority of the infected patients, they develop the rheumatic fever, as I told you. Only 3% of them will develop. This is because of the genetic susceptibility. So initially, as I told you, in the heart, when we see the myosin, troponin, all those are present in the valvular tissue. So how does the antibodies act on the molecules which are present within the valve tissues? So we have to see that initially the antibodies, it will act on the laminin and the vimentin which are present on the endothelial cells. Now these endothelial cells, when the antibodies attack them, they get activated. And once they get activated, or they are somewhat damaged also, once they get activated, they express the vascular cell adhesion molecule 1, VCAM1. Now this VCAM is mainly responsible for the adhesion of the T lymphocytes. And these T lymphocytes, they enter through the endothelial cells into the valve tissues. Now, once they enter the valve tissues, they start destroying the myosin. Both CD4 and CD plus T cells infiltrate, but only autoreactive T cells survive, because autoreactive cells are the ones which act against the cardiac myosin troponin. So only those cells which are autoreactive, they survive. This is how the T cells, they enter into the valve tissue, causing damage to the valve tissues. Now, during this process, when the endothelial cells are damaged, there will be some loss of the normal endothelial cells also, and then there is a modification of the valvular collagen. Now, these valvular collagen, after the destruction of the endothelial cells, it forms an aggregate, and the antibodies are formed against this aggregated collagen which is released. Now, this is not an autoimmune reaction, remember. This collagen doesn't have any mimicry with the M protein, but instead, aggregated collagen antibodies are formed against this aggregated collagen which is released out when the endothelium is damaged. And slowly the antibodies, when the endothelium is lost, they enter into the tissues, and here in the valve tissues, they act against cardiac myosin and the troponin. Now, continuously they act, causing destruction. The macrophages which are present, they produce the growth factors, and they cause the fibroblastic proliferation also. And this, along with the antibodies, CD4 plus T cells, which are activated by the streptococcal antigens, also cross-react with the cardiac antigens. So we have destruction of the valve tissues by the CD4 plus T cells, and also by the antibodies which are entering into the valve tissues. Now, the inflammatory process initially destroys the valvular tissue. Later on, this inflammatory infiltrate further extends into the papillary muscles, which that contains the myosin within its cardiomyocytes. So we have the papillary muscles and chordae tendineae, which even have the cardiomyocytes. So the inflammatory infiltrate further extends into this and causing destruction of the chordae tendineae, and also even the adjacent myocardium, because that also has the myosin and the troponin. Now, when the autoantibodies are produced in excessive amounts, that leads to formation of the Ashkoff bodies. Now, what are the Ashkoff bodies? We will see in the morphology. Now, this also I told you, angiotensin 2, which is produced by the macrophages, it is mainly responsible for the fibrosis. Now, how does it cause fibrosis? This is because angiotensin 2, it stimulates transforming growth factor beta. Now, this is the one which causes a fibroblast activation and proliferation. Not only the transforming growth factor beta, it also stimulates the ST2-deoxy receptor. Now, when this receptor is stimulated, there is increased phosphorylation in the mitogen activated protein kinase pathway. So this causes further cell proliferation, differentiation, growth, and altered gene expression. So this one, it also causes the fibroblast activation and proliferation. So totally angiotensin 2, what does it do is, it stimulates transforming growth factor beta and also ST2-deoxy receptors, which finally causes fibroblast activation and proliferation. So fibroblasts, when they are activated, they proliferate and they produce lots of collagen in between, because of which the valve tissue is thickened and it becomes more fibrotic. Now that was about the pathogenesis. Now we'll see the morphology. When we see the morphological changes, the different organs which are involved are heart, joints, CNS, and the skin. So in the heart again, pericardium, myocardium, endocardium, all the three are also involved. So when we take the pericardium, typically it has been thought that there is some pericardial antigen which is involved in this autoimmune reaction, and typically it involves only the T cell mediated reaction. Okay, in the pericardium, it involves only T cell mediated reaction. And when we see the pericardium, we have two layers in the pericardium. One is the parietal pericardium, which is present just adjacent to the heart muscle, and another one is a visceral pericardium, which is present adjacent to the chest wall structures. And in between the two pericardiums, we have the pericardial cavity. So we have a minimum fluid in this pericardial cavity so that the movement of the heart is made easier. Now, when there is infection in the rheumatic fever, what happens is the thickness of the pericardium, it increases. Parietal pericardium is increased, and also the visceral pericardium. Both the thickness is increased, and there is a fibrinous exudate in between the two pericardial cavities. So this fibrinous exudate will be somewhat granular. So when we see the pericardium, both layers of pericardium are thickened, covered by shaggy fibrinous exudate. Now this appearance, how it appears is when we take the two bread slices, apply a butter in between, then press the two bread slices and pull them apart. So we have that butter gives a granular appearance. So this here the appearance in between the two pericardial surfaces will be similar. That's why it's also called as bread and butter pericarditis. Okay, so another name of pericarditis in the rheumatic fever is bread and butter pericarditis. So microscopically when we see, it shows deposition of fibrin material and we have even the leukocytic exudate. So because of this pericarditis, there will be pain and the friction rub will be present. Now that was about the pericardium. Then what are the changes in the myocardium? So we have myocarditis. Then in the myocardium, the patient will have fibrinoid necrosis and the Ashkoff bodies. Now what are these Ashkoff bodies? They are composed of T lymphocytes, occasional plasma cells, and plump activated macrophages, which are called as Anichko cells. So these macrophages, they have abundant cytoplasm. You are seeing here, these are the macrophages which are having abundant cytoplasm, but the nucleus is ovoid and the chromatin is condensed in the center. You see this is that Anichko cell, and the chromatin is condensed in the center and slender, wavy, and appears like a caterpillar. So hence it's also called as a caterpillar cell. And when we see the cut section, they resemble the oval eye. So these cells have the oval-eyed appearance also, and some of them can be binucleated also. So we have lymphocytes, T lymphocytes, plasma cells, and Anichko cells which have the caterpillar-like the nuclei or the oval-eyed nuclei. These are the Ashkoff bodies, and in the center we have fibrinoid necrosis. So because of these Ashkoff bodies, there is damage to the muscle. So there is a decreased contractility. When there is a decreased contractility, obviously there is a decreased cardiac output, and this leads to congestive heart failure. Then what are the changes in the endocardium? So we have seen pericardium, bread and butter pericarditis. In the myocardium, we have Ashkoff bodies. Then in the endocardium, we have certain valvular changes. As the myocardium is damaged, there is a dilatation of the annular ring. So if the annular ring is intact, both the valves will close correctly so that the blood doesn't leak out. And when there is a dilatation of the annular ring, both the valves cannot close properly and you have a space in between. So this causes a regurgitation. Another thing is because there is a damage to the chordae tendineae, they become thin and they are elongated, so that the movement of the valve is not controlled. So they become floppy like valves. They move inside also. So this causes again the regurgitation. So both dilatation of the annular ring and you have elongation of chordae tendineae, both of them are responsible for the inadequate coaptation of valve leaflets, which causes the valvular regurgitation. Now another one is other changes is because the endothelium is damaged, there can be formation of the fibrinous vegetation on the rough zone on the leaflets. And along with that scarring of the leaflets, both of them they causes the valvular stenosis. So these are the valvular changes. Further changes we have. So because endothelium is damaged, I told you vegetations can develop, and typically these vegetations are called verrucous vegetations, and they are present at the closing edge of the valve. They are gray white translucent, present at the closing edge, and because of the commissural fusion and calcification, the valve becomes stiffened and stenosis occurs, and typically this stenosis they call it as a fish mouth stenosis. So if you see this, it resembles the fish mouth. This is because of commissural fusion and the calcifications. Then we have another one in the left atrium called as a McCullum's patch. So already I told you on the valves there will be the formation of the vegetations, commissural fusion. So we have a stenosis in the valve. So the valve cannot open properly. So immediately there will be a regurgitation jet will be there. So this regurgitation jet, as it will be continuously hitting the back wall of the atrium, that produces damage to the endothelium there, and that causes a thickening of the endometrium. And that patch which is thickened, we call it as a McCullum's patch. Okay, then left atrium slowly dilates and it harbors mural thrombi that can embolize also. So these are all the changes in the valvular tissue. And in chronic rheumatic heart disease, the patient will have the thickened leaflet. This is because of the fibrosis. Then strong thickening and fusion of the tendinous cords occurs, and we have a commissural fusion which causes a stenosis of the valve. So in all these changes we see typically in the mitral valve. Most commonly the valve which is involved is the mitral valve. Next involved is the aortic valve. So if it is asked that which valve is commonly involved, it should be the mitral valve. Then if all the three are involved, endocardium, myocardium and pericardium, we call it as a pancarditis. Then coming to the joints, typically the antibodies, they cross-react against the vimentin which is present here, and also against the collagen, because as I told you, first initially the damage to the heart occurs and then the collagen is released, to which the antibodies are formed. So those antibodies also act in the joint. They act against the vimentin and the collagen which is present in the synovial membrane. So when they attack, they form an antigen antibody complex, and this complex, it recruits the inflammatory cells, causing the damage to the joint, causing the arthritis. And typically the arthritis is migratory polyarthritis. That is, first one large joint is involved, it becomes very painful, swollen, then it subsides, and then again another joint gets involved. So this is called as migratory polyarthritis, and most commonly the joints involved are the large joints. Then coming to the CNS involvement, antibodies attack the neurons which are present in the basal ganglia. Basal ganglia, it consists of the caudate nucleus, we have putamen, globus pallidus, and the subthalamic nucleus and substantia nigra. So neurons which are present there, they are attacked by the antibodies, and typically in the neurons, antibodies attack the lysogangliocytes and the dopamine D1 and the D2 receptors. So when antibodies attack these lysogangliocytes and D1 and D2 receptors, this causes activation of calcium calmodulin dependent protein kinase type 2. So when there is an activated K2 activation, then we have increase in the tyrosine hydroxylase. Now this increase in the tyrosine hydroxylase, it causes increase in the dopamine release. So when lots of dopamine is released, it stimulates the nerves and it causes the abnormal movements. So this produces the Sydenham's chorea. So this is characterized by uncontrolled and rapid movements of extremities, face and the tongue. So this is the main cause for the Sydenham's chorea in the rheumatic fever. Now the changes in the skin, we have two lesions, erythema marginatum and subcutaneous nodules. Erythema, these are mainly because the antibodies attack the keratin. So erythema marginatum, it is because of the cross reaction of the antibodies with the keratin. Typically the lesion will have peripheral central pale area which is surrounded by raised erythematous area at the periphery. Red border will be present at the periphery. And also they developed subcutaneous collagen nodules. This is mainly due to the delayed hypersensitivity against the group A streptococcal antigens that leads to deposition of the collagen. Now these are just the painless nodules. These collagen nodules are the painless nodules which we see on the joints like the back of the wrist, elbow, knees, ankles and the knuckles. So these are the changes we see in the skin. Now for the diagnosis of the rheumatic fever, Jones criteria has been given. So in the Jones criteria, we have a major criteria and the minor criteria. So the major criteria are migratory polyarthritis of the large joints, pancarditis, subcutaneous nodules, then erythema marginatum, and we have a Sydenham's chorea. So to remember, just remember the Jones only. J is for joints. O, instead of that, you remember the heart, that's pancarditis. N is for nodules, subcutaneous nodules. E is for erythema marginatum, and S is Sydenham's chorea. So these are the major criteria, and when we see the minor criteria, the patient has a fever, monoarthralgia, elevated blood levels of acute phase reactants, that is C-reactive protein, raised ESR, and prolonged PR intervals. So these are the minor criteria. Just if you have to remember the criteria, Jones criteria, just remember this, Jones phase P. So Jones is for the major criteria, phase P is for the minor criteria. Now, what is the diagnostic criteria for the rheumatic fever is the patient either should have evidence of antecedent streptococcal infection, that is throat swab culture or rapid antigen test should be positive, or otherwise there should be elevated or increased streptolysin O titers in the serum. Now, along with this, there should be two major criteria or one major and the two minor criteria should be present. Now, if this is present, then we can diagnose that it's a rheumatic fever. Now, clinical features, it depends upon the organs involved. So, on the heart, because of pericardial involvement, the patient will have pericardial friction rub. Because of the myocardial involvement, there can be the heart failure. Then, when the valve tissue is involved, there we have a thickened valves, commissural fusion, vegetations on the valve leading to the stenosis. So, there will be regurgitation in the cardiac murmurs. And in the chronic rheumatic heart disease, the patient will develop arrhythmias and thromboembolic complications and infective endocarditis. So these are all the clinical features when the patient has involvement of the heart. And if the joints are involved, we have migratory polyarthritis, and the skin, it shows erythema marginatum and subcutaneous nodules. Approximately 1% of affected individuals, they die of fulminant rheumatic fever involvement of the heart. So depending upon which organ is involved, the presentation of the patient will be different. Now, complications of the rheumatic fever are adhesive pericarditis, infective endocarditis, then mural thrombi in the atrial and the ventricular chambers, thromboemboli, and congestive heart failures and arrhythmias. So adhesive pericarditis, it develops after the fibrinous pericarditis. As a healing process, adhesions develop. Infective endocarditis is on the damaged walls. We have the deposition and growth of the bacteria. Thrombi we see in the atria because of the regurgitations, atria and ventricles. And thromboemboli is the vegetations which are formed, or the thrombus which is formed, it can embolize and produce an infarction of the various organs. So to remember, just remember PET CAT are the complications. P stands for pericarditis, E for endocarditis, T for thromboembolic complications or mural thrombi, C for congestive heart failure, A for arrhythmias, and T for thromboembolic complications. PET-CAT. Now, treatment is primarily with antibiotics like penicillin to control the infection, and then when the patient develops the complications, it will be the medical treatment if the patient has congestive heart failure, or otherwise it should be surgical repair and replacement of the diseased valves. When we come to the summary, first we'll see the definition. So definition is acute immunologically mediated multisystem inflammatory disease, classically occurring 10 days to 6 weeks after the pharyngitis caused by group A beta hemolytic streptococcal. And when we see the age group, acute rheumatic fever is more common in the children, whereas the chronic rheumatic heart disease is more common in the adulthood. And the pathogenesis is mainly, it is because of the cross reactivity of the antibodies against M protein of beta hemolytic streptococci with cardiac myosin, keratin, laminin, vimentin, and the gangliosides. So organs involved, when we see, we have heart, joints, CNS, and the skin. In the heart, pericardium is involved. It produces the fibrinous pericarditis, also called as bread and butter pericarditis. In the myocardium, we have myocarditis with the Ashkoff bodies, and in the endocardium, we have the valvular tissue which is involved. So valves, there can be thickening and elongation of the valves. Vegetations can be present in the valves. Then elongation of chordae tendineae can occur. Fish mouth stenosis because of commissural fusion and calcifications. Then later shortening and thickening of the cords can occur. And McCallum's plaque is formed in the left atrium because of the regurgitant jet. Now in the joints, we have migratory polyarthritis involving the large joints. CNS, we have the Sydenham's chorea, Then in the skin, we have erythema marginatum and subcutaneous collagen nodules. So complications when we see, remember the PET CAT, that is pericarditis, endocarditis, mural thrombi, congestive heart failure, arrhythmias, and thromboembolic complications. Then in the Jones criteria, the diagnostic criteria, they take it as a Jones criteria. Here we have the major and the minor criteria. So the patient should have two major criteria or one major and two minor criteria along with the antecedent evidence or evidence of the antecedent or preceding streptococcal infections. So if we have this, definite diagnosis of the rheumatic fever is made. Thank you, friends. Thank you for listening patiently.